Good afternoon, everyone. We welcome you today to this special webinar organized by Thalassemia India and Thalassemia Patient Advocacy Group on a very, very important subject, Luspatercept in TDT and NTDT. These are terms I don't need to explain to anyone. And we are all looking forward to hearing our esteemed speakers and our chairpersons today. I hand over now to I invite Mr. Deepak Chopra, President Thalassemia India, to please come and give the welcome address. You are on mute, sir.
Hello, can you hear me now? Am I audible?
Yes, you are audible.
Yes.
Good morning to us. Good morning to some, good afternoon to many, and good day to each one of you. I know we are very eager to listen to experts on this very important subject, which covers a new drug known as Luspatercept. And earlier, I would say the generic form, which was heard more often, was Reblozyl. I am not going to go into any detail because I don't have details with me. I don't have knowledge. There are experts like Dr. Antonio Piga, Dr. Mamta Maglani, Dr. Tulika Seth, Dr. Namita Kumar, Dr. Sunil Bhatt, Dr. V.K. Khanna, and not to forget our favorite doctor, who's also the moderator, I think, in one of the panels, Dr. Amita Mahajan. We are all eagerly waiting to hear from each one of them, not about so much as to what this drug is going to do and what not it is going to do, because I think most of you who are on the panels or who are now slowly joining in, you are fully aware about the drug. I am quite sure that there would be questions or queries or anxiety to know about the usage of the drug overseas up till now, its efficacy, its after effects, if any. And as far as Indian users are concerned, I think the most important thing which we are all wanting to hear is to how much it's going to cost our pocket. I'm given to understand that the pharma company BMS, who is going to bring it into India, are looking at the first quarter of 2023. I hope they are able to live up to that milestone. But more importantly, I would impress upon, and I hope that they are also today, in one form or the other, a part of this webinar, that this big group, from Dr. Piga to Dr. Amita Mahajan, will certainly have some sort of a leverage on them to impress upon the importance of Indian market, the numbers which India has, and also the economic conditions of most of the patients who are going to be taking this particular drug. I'm quite sure that each one of you would certainly have that as your prime goal. So without taking much more formalities, I would request my co-member of the Thalassemics India team, Gagan, to take over. And I sincerely hope that the interaction and deliberations, especially the question answer session, will benefit all those who have registered and are in the process of joining online. Over to Gagan.
Thank you, Mr. Chopra. Thank you very much for the kind words. And yes, we are all looking forward to today's webinar. But before we proceed, I would like to introduce our chairpersons for today. So may I introduce Dr. Mamta Manglani, Chairman PHOIAP, Director of Comprehensive Thalassemia Care Pediatric Oncology Hematology, BMT Center, Mumbai. Our next chairperson for today, thank you, Dr. Manglani, for joining us today. Our next chairperson for today is Dr. V.K. Khanna, a name and a person we all know very well. He is the chairperson, Department of Pediatrics, Sir Ganga Ram Hospital, New Delhi, Vice President, Thalassemics India. Thank you, Dr. Khanna. And our next chairperson for today is Dr. Tulika Seth, Professor Hematology, All India Institute of Medical Sciences, New Delhi. Thank you, Dr. Tulika Seth. And our very special guest for today is Dr. Sunil Bhatt, who is the Director and Clinical Lead, Pediatric Hematology, Oncology, and Blood and Bone Marrow Transplantation, Narayana Health Network Hospitals, Bengaluru. Thank you, Dr. Bhatt. So I now hand over to our chairpersons for today, if we can have them all on the screen, please, to say a word. And then, of course, Dr. Manglani can start the proceedings by introducing Dr. Piga. Thank you.
Thank you, Gagan. It's indeed a pleasure to be part of this auspicious panel. And I thank Thalassemics India and the Thalassemia Patients Advocacy Group for inviting me to be chairing this session as one of the chairpersons. On behalf of my co-chairpersons and myself, I sincerely extend my gratitude to you. And a warm welcome to all who are participating in the today's deliberations. So to introduce Dr. Antonio Piga is a huge task, because he is a person who has great contribution to the field of thalassemia. Ever since we have been learning about thalassemia, we have read his articles and his publications, not to mention that we follow a lot of his recommendations in our day-to-day practice. So Dr. Antonio Piga is a professor of pediatrics and dean of medicine at the San Luigi University Hospital of the Turin University, Italy. And he shall be deliberating on Luspatercept, the global perspective today. I'm sure he'll enlighten all of us better on what is the overall world perspective of Luspatercept, especially in his part of the world. So I welcome Dr. Antonio to take over the stage. Thank you.
Thank you very much for this very kind introduction. And I will try to cover the topic for the global perspective on this new drug, starting from the factory of red blood cell that is a very efficient, in normal people, it's a very efficient factory that produce functional red blood cell, erythrocyte, but is a complicated one. In thalassemia is not efficient. So for thalassemia, the standard treatment in severe cases is to give transfusion, chelation, and supportive treatment. So where are the other treatments for thalassemia? There are treatments that go directly to the first cell of the factory, that is the stem cell, hematopoietic stem cell, with the hematopoietic stem cell transplantation, or more recently with gene therapy, with gene addition or gene editing, and try to solve the thalassemia at the root in this way. Where is Luspatercept on this? Luspatercept is at this point, that is, Luspatercept is not going to the stem cell, is not correcting the gene for the hemoglobin, but is going to the main feature of thalassemia, that is ineffective erythropoiesis, when the red blood cells start to be done. And differently from normal people, there is in thalassemia a very, very poor final production of red blood cell, mature red blood cells, so anemia and severe anemia, but a great expansion of the production with a lot of immature cells produced in the bone marrow that expanded, etc., what you know very well. So where is, why this is? Because in thalassemia, as in a few other diseases, there is an overproduction of these substances that are, let's say, ligands that give the signal to produce a lot, but not to go on with maturation, the final red blood cell. And so, where is Luspatercept? Luspatercept is this one, is like a trap because mimics a receptor, the main receptor on the red blood cell, and is able, once injected, is able to trap most of the excess of the ligands. So decrease this expanded signaling and so improve the maturation. So at the end of the day, we have with Luspatercept a production of red blood cells that are still thalassemic, but the number is more and also the function is better. Being such a sophisticated molecule that is a protein, a complex protein, a fusion protein artificially produced in the lab, is not possible to have, as for many drugs, a pill, a simple drug to be taken orally, but must be injected. Luckily, it's enough to inject these once every 3 weeks. And so, which are the results from the clinical trial that is running now since several years on these new drugs? So in thalassemia intermediate, that is patients that do not need the regular transfusion, the results are of this type. You see here one real world, one of our patients, the first one we treated in a clinical trial. So you see a thalassemia intermediate living with an hemoglobin around 9, and then you see in blue triangles, the injection every 3 weeks, and you can see the total hemoglobin rising up. And then this was the first trial. We stopped the drug, we waited some time, wash out, and then we started again with the drug, and you see again the hemoglobin rising up a bit. Enough, not enough, it depends on the point of view. In green, you see, we call reticulocytes that are the new produced red blood cell, the new one produced by the patient with thalassemia. So, and you see also the new cells are more than without the drug. This is basically, on the average, the gain in the hemoglobin with Luspatercept is this one in thalassemia intermediate. You see 1 gram, 1.5 gram, but you see these bars. We use these bars to quantify the variability from a patient to another patient. So a lot of variability. Patient respond poorly, and other patient responds very well. And we do have many other type of effect on other aspect of thalassemia, but obviously I don't have time to enter these other details. So when we went to clinical trial with a very strong scientific design, that is randomized controlled trial, checking the effect of luspatercept here against nothing, a placebo, a false, a fake drug, you see that this gain of hemoglobin is kept in most of the patient, at least 1 gram on the average, or at least half of the patient, 1.5 grams. This is on the average, but you see that there are patients that respond beautifully, a few, and patients that do not respond at all, a few, again. On long term, what happened? There is a loss of this effect? No, at all. These are the results we published from the clinical trial on long term. And you see here you have 5 years on long term, and you see there is no loss of response. And we have now, the first patient are now 8-9 years taking luspatercept. Just a few patients, the number of those, but there is no trend to lose this effect. And this is the publication that is just published a few days ago. So what's about from clinical trial in transfusion-dependent thalassemia? So it's more complicated in transfusion-dependent thalassemia because we have to go and check the effect on transfusion. So there is a gain in lowering the transfusional need. So we have to measure the transfusional need. This again is one of the first patients we treated. You see transfusion, you see 3 units every 30 something days receiving to maintain a mean hemoglobin around 10. So what happened when we start luspatercept? You see the effect. That is maintaining, roughly speaking, the same hemoglobin, maybe something more, but using less blood unit. You see, we were using, 2 units instead of 3 at each transfusional event, and having also a prolongation of the interval sometimes. So the gain, the lowering of transfusional need was something around 40%. And this, in the published result, you see that this single patient is this bar. You see that is this effect. So again, you see the variability. There are patients that do not respond at all, this patient, and there are patients that respond in a better way than this one. And again, when we switch to the randomized controlled trial to verify these, we saw that giving luspatercept in most of the patients, we do have a response. Here you see in dark green a response of more than 50% reduction in transfusional burden, and in light green a response less than 50% reduction. So great variability, but the response is that in comparison with placebo, where you have some response measuring this burden, but just a few patients. What's about the safety of this compound? So you see here again, in the controlled trial, the comparison of luspatercept, the most common symptoms and adverse event in comparison with placebo. So patient with thalassemia not taking the drug. And you see headache, arthralgia, bone pain, cold, and dizziness, nausea, etc. You have an effect from the drug, yes, but you may have the net effect looking at the difference in comparison with patient not taking the drug. So there is an effect, but most of these symptoms have a trend to disappear after the first weeks of treatments. So, but this has been the result from clinical trial. What's about the clinical practice? Because to go to the clinical practice is a different way. So there are steps that must be taken. The first, obviously, is the approval. And so we had the first approval of this drug has been years ago. You see, November, 3 years ago. In US, the FDA approved the Luspatercept in US 3 years ago. And then after some months, there has been the approval in Europe for all the European countries by the European Medicine Agency. And but this happened in 2020. In Italy, in example, we do have the approval has been translated on the practical fields only 1 year after that. Then there is the problem of the cost. Are the costs affordable? Which is the cost that is fixed? Just to give you 2 examples. In Italy, the cost is this. You see, this is the cost of each vial that is commercialized, vials of 25 mg and or vials of 75 mg. But what is important, I did here a calculation that is 1 year treatment needs 17 injections. And this is the mean dosage per kilo. So if I take a patient with thalassemia of 50 kilos, in Italy, the price is this one. So a very high price. It's true that the hospital, because we have the drug through our hospital, each hospital, and not the drug shop, there is some discount. But in any case, the cost is high. If we go to the first country that approved, that is US, you see that in US dollar, but now is the same, the cost is double of the, let's say, European cost. But you know that the US, from the points of view of drugs, it's a world apart. That is, the cost, generally speaking, is higher. But if we come, and this is a drug that is not curing thalassemia, is not a drug that given take out thalassemia. If we go to see the first approval we had recently of gene therapy for thalassemia, and this happened in Europe more than 1 year ago, but then the approval has not become real. In US, there has been the approval of the first gene therapy for thalassemia in August this year, and it became the most expensive drug in the world. So thalassemia in US received the most expensive drug in the world. That is one shot, that is gene therapy, and it cost in US 2.8 million. And where successful is curing, obviously there is some risk, etc., but I will not enter this if not in the discussion. And for some months, thalassemia, at least in the US, had a drug approved and is approved now for the patient in US, and is really very expensive. But a few days ago, a new gene therapy for another disease that is hemophilia B, received the approval again in US and only in US. And you see the price, the cost that is covered, 3.5 million. So our cost, from my point of view, I'm a physician treating patients, is no sense, this cost. Even if from the balance, looking at the cost of the life of a thalassemia patient treated in US with everything and the standard, is true that if we go to 2.8 million, it's true that the cost is something that is taking in account everything, that may be 50 years of the life of a thalassemia patient, well treated, transfusion dependent, chelation, test, care, etc., maybe something around this. That is very true. So the key point, passing from the clinical trials to clinical practice, is the availability. And so availability is depending a lot also on local aspects. So for India, I am the most ignorant of this seminar, so I don't say nothing. And finally, the patient selection. And for this, I can say something because I have now some experience of years using this drug. So patient selection is very important, and having an effect very variable, it's obvious that it is key to go to the individual patient and trying with the individual patient to see from his characteristics, to try to guess the response to the drug, yes or no. But before guessing this, and we tried, in example, in Italy, as we have a medical, a scientific society for thalassemia and sickle cell disease and hemoglobinopathies. We did, and Dr. Longo in particular, with other experts, they prepare some sort of good clinical practice on luspatercept with the dose and on questions and answer from expert on the drug, like this one very simple question, like is there a maximum age limit for prescribing luspatercept? Yes, no, with obviously answer that is no maximum age limit, or more interesting question like this, the genotype of thalassemia, you know, beta 0, beta plus, etc., is needed or not, where to prescribe, there is no need to have the genotype testing. It's enough to be transfusion dependent, adult. And but the panel of experts suggested that to have the genotype is useful for confirming the diagnosis, but more importantly, to look at the patient and look at the result and the response and to compare with others. But the first point before prescribing luspatercept is obviously the safety, as for any drug. So generally speaking, the basic points are that there is no specific contraindication for luspatercept, but there are special warnings and precaution, because we had a chance of thrombosis, of thromboembolism, that is blood clotting, that is around 4%. So this is the risk, but obviously this risk may be very different in different patients, from patients that have a risk that is by far less than this to patients that may have a risk that is something like 40%. So if I evaluate carefully my patient and I see with my patient that the risk is something like 40%, I do not suggest the luspatercept to this specific patient. I say to the patient, no, please, I will not prescribe to you luspatercept because the risk it's important. Hypertension, same with luspatercept. You may have some trend, a small trend to rise of the blood pressure, even to hypertension, but I know that in thalassemia there is a trend to hypotension, so low pressure, but again, it's a warning. The same for extramedullary hematopoietic masses that are very, very common in thalassemia. So the risk to have a trend of these masses to rise a bit or rise importantly is this. It's a small risk, yes, but I have to set my individual patient very well before starting and before discussing with the patient, and then discussing with the patient. Obviously, it's a type of drug that must not be used during pregnancy. And so for the adverse reaction, we told, and are not as important as it seemed, are not important. In my experience, are not important. And this is the end of my talk. Thank you very much.
Thank you, Dr. Piga, for a wonderfully lucidly elaborated global perspective on luspatercept. I'm sure there are many, many questions which will be upcoming later. I myself have a couple of questions, but we'll take them later. I thank you immensely for this wonderful talk that you've delivered. Thank you. Over to Gagan.
Thank you, Dr. Mamta, and thank you, Dr. Piga. Over to Dr. Khanna to introduce our next speaker, Dr. Amita Mahajan, please.
Our next speaker is Dr. Amita Mahajan. She is a senior consultant pediatric hematology oncology at Indraprastha Apollo Hospital, New Delhi. We all know that she is a very dedicated professional and a very valued medical advisor to Thalassemics India and other organizations like Foundation Against Thalassemia and Can Kids. And she's going to speak on practical considerations on this drug. Now I invite Dr. Amita Mahajan to start the presentation, please. Dr. Mahajan,
Thank you,
please.
Dr. Khanna, for your kind words, and a very good afternoon and namaskar to each and every one of you. I'll just share my slides. Gagan, I may have to request you because it's again not allowing me to share for some reason.
Sure. Darshan, can you share Dr. Amita's presentation, please?
Yes, ma'am.
Thank you, Dr. Piga. Your talk was wonderful and such a balanced talk. I want to share with all the parent and patient community that have joined us today that this is not from the company at all. We know that the drug is about to be launched shortly in India, and as the patient and parent community in India is thalassemia community is really keeps abreast with all the developments. So in order to prepare them as to what to expect from this drug, we thought it would be worthwhile that we invest, and maybe we could do one again closer, after the launch, but just to prepare and what our parents, can expect or patients can expect, from this drug. So Dr. Piga has been involved in the trials. He has practical experience. Can I go to the next slide? So in disclosures, we have no conflict of interest with the company, but I do have a disclosure that whatever I'm going to share is from literature in the public domain and speaking to people who have used the drug and speaking directly from inquiries from the company. So we have not yet had a chance to use the drug with us. Next slide. I just estimated that for an average patient with transfusion-dependent thalassemia, over a period of 50 years, they are likely to receive 1,800 units of packed red cells. And unfortunately, most of thalassemics are in the part of the world where regular access to safe blood we cannot take it for granted. The WHO has estimated that within the thalassemics globally, 22,500 deaths occur due to under-transfusion directly. Even where access is there are physical and psychological consequences of this lifelong condition. And also we have to deal with the consequent iron overload. So it's it doesn't take a lot of things to think that a lot of efforts have been made over the last few years to find a way to reduce the transfusion requirement and dependence in patients. Next slide. So sometimes, even though you are trying to find a solution, it doesn't happen. And accidentally you discover, a particular, quality of a drug that may be used for something else. So Sotatercept and Luspatercept were originally being developed to treat osteoporosis and osteopenia. But these studies unexpectedly revealed increased hemoglobin levels in treated patients. And again, then the mechanism of action was discovered, and now we understand the mechanism of action. Dr. Piga explained it so nicely that it promotes late stage maturation or erythropoiesis, thereby reducing red cell destruction and increasing the lifespan so that we require less transfusion. Next slide. This is just to show again, because this is mostly parents and parents have joined. So the Luspatercept acts at a specific point, which kind of allows, suppresses ineffective erythropoiesis and allows late, maturation of red cells. Next slide. So how did we, evolve? So once this was discovered accidentally, then this drug was evaluated in mouse models. And as happens in the, development of any drug, the next step was to test in healthy volunteers. It was well tolerated. Most of them had some increment and no serious adverse events were observed. Then it went to a phase 2 study, which means a dose finding study. And again, it was found that most patients had some benefit and the common side effects were identified. And finally, we had the phase 3 study that Dr. Piga shared, that half, patients are randomized. They either receive some fake drug or they receive the real drug, but nobody knows to really understand the impact of this drug. Next slide. So the drug he already shared was approved in US FDA in November 19. It was approved in Europe in 2020. We have the DCGI approval this year. And I think one encouraging thing one can see is the gap between FDA approval and DCGI approval is narrowing, because pharmaceutical industries also recognize that, where the numbers are and where the big markets are. So they are bringing drugs sooner to India than it used to be. So the drug is currently licensed to treat anemia in adult patients, that is over 18 years of age, with beta thalassemia who require red blood transfusions, and also for another indication, low risk myelodysplastic syndrome, but we will be talking only of thalassemia. Next slide. So this is the drug he's already shared. The drug, when it comes to India, will be carrying a different name, but it will have the same strength. It will be just like Exjade was launched in India as Asundra. Reblozyl will be launched, but it will be in the same milligram. Exjade is 500 and Asundra is 400, but these vials will be same. Next slide. This again just shows how, the process, it doesn't happen overnight. It takes time. Lot of safety, efficacy considerations are taken into account. Next slide. So what are the practical issues that we are going to, what the parents would like to, or patients would like to know? Who is eligible to receive this drug? How effective is it? How is it given? How long does it take to know the response? Is there any impact on iron overload? What are the short-term and long-term effects? And in our country, economics primarily drives healthcare, so cost will remain the most important question. Next slide. So at the moment, adults with transfusion-dependent thalassemia who have received at least 2 units in the preceding 8 weeks are eligible to receive a trial of this drug. Patients with E-beta thalassemia who are transfusion dependent were part of the original cohort, and if they are, this category may also be considered. NTDT is being evaluated, and with positive results, but it is not yet licensed for NTDT or any other hemoglobinopathies. Next slide. How effective is it? So the response varies from person to person. So when they were, this is from the BELIEVE study, that if they looked at in the first 12 weeks after starting, 21% achieved 1/3 reduction. And if they looked at any 12 weeks after starting, so they were given for 48 or 10, a total of 12, 48 weeks. And in any 3-month period, 70% had a 1/3 reduction. Transfusion independence was achieved by 11% of the patients up to 8 weeks. So patient response varies from patient to patient. But the important thing is that most patients, if they are going to respond, will respond in the first few weeks. And that's very important, that we don't have to keep trying for many months to realize that am I going to, or my child is going to benefit or not. We will know the response immediately. Next slide. So at the moment, could you move the slide? At the moment, there is no way to predict who will respond or not respond. Dr. Piga already said the genotype, no other age, ethnicity, we have not been able to identify any factors, but we know that those who have non-beta 0, that those who make some effective hemoglobin anyway are possibly, a better place to respond. Darshan, could you move the slide? Yeah. So the magnitude is there, but again, no real predictor. But the important thing is that those patients who respond
seem to retain their response as long as the drug is given. So there is no tachyphylaxis or loss of this response. So that is also important to know. Next slide. How is it given? It is given as a subcutaneous injection once every 3 weeks. We are meant to check the hemoglobin before each dose, so that if there has been a very good response, we may need to lower the dose. If the transfusion has happened before the dose, we have to use the hemoglobin just before the transfusion to evaluate the response to the drug. And it is very important in the first few weeks to assess response, because like I said, the response is seen almost straight away. So if we give 2 doses, 6 weeks at the lower dose, if the patient does not respond, we can go up to a slightly higher dose. And if he does not respond to 3 doses of this, then we can say that the patient is not going to respond and stop the drug. So a total of 5 doses, and given 3 weekly, and we can take a call that we are not going to respond. There is no point in continuing beyond that. Next. So up again, there will be some very prompt responders and very high responders. So in those, we may need to actually reduce the drug, and the package insert will clearly tell us as to how we have to go about that. Of course, if you see any major side effect, then we anyway would stop the drug immediately. Next slide. So this is just the chart, because there is a clear guideline on how to, if we have very good response or suboptimal response, how to adjust the doses. Next slide. So important thing, what are the short-term side effects that we expect to see? As you can see, the drug was being designed for patients with bone density loss, osteoporosis and osteopenia. So the commonest side effects are actually musculoskeletal pain and arthralgias. Patients have reported fatigue or headache, and about 10% have reported hypertension. So what is all makes clear is that this drug has to be used under close medical supervision. At 15% observed at least one event, serious event, for which maybe sometimes drug needs to be modified, but I think less than 5% needed discontinuation of the drug. What is important is that 3.6 or 4% had a major event with clotting, thromboembolic event. And the ones who had this were patients who we know are at very high risk of having a thrombotic event. And one of the questions that was already in the chat box was that, can somebody who has undergone splenectomy receive this drug or not? They can receive, it's not contraindicated, but we need to be more cautious. If such an event occurs, then one has to weigh the risk versus benefit ratio and either use anti-clotting medication along with it or discontinue the drug. But this all I want to just highlight is that this all will need for our doctor community also to understand this drug, how to use this drug, and we use this drug very judiciously. Next slide. So the warnings that come with this drug are about the clotting events that we need to be careful about monitoring of blood pressure, because it is licensed for adults, and many of our thalassemics are now in their 40s and crossing 50. So they are at their age where they may get all the adult problems as other healthy people. Next slide. What are the long-term side effects? Dr. Piga has already said that the drug has been there now for many years, and all the patients in clinical studies are being continuously monitored for any long-term side effects. And so far, no new challenges have been identified with the passing years. Next slide. So is there any impact on iron overload? If we are if they require less blood, maybe their iron load should also come down. So in the study, because it looked at only 48 weeks, there was a modest increase in serum ferritin, but no decrease in serum ferritin, but no significant decrease was seen in the T2 star MRI. But it was perhaps very short interval. Subsequent follow-up data has shown that in patients who have, especially those who have had a good response, their liver and cardiac iron load also decreases because their transfusions will be lesser. Next. Pregnancy is an absolute contraindication, and breastfeeding mothers are also not supposed to be taking this medication. Women in the reproductive age group, they should take contraception if they are not planning to have a baby. But if they are, then they should, at least for the time being, avoid this drug. The fertility impact is just very transient, and in the studies that it recovers back to normal within 3 months after discontinuing the drug. Next slide. The drug is to be stored at room temperature for up to 8 hours. It comes as a powder. It has to be reconstituted, and the reconstituted product we should use, as quickly as possible. If, in India, we multi-dose, as we often do for economic constraints, then 2 patients must plan to have it at the same time on the same day, so that they can, maybe have some economic advantage. But the drug is not meant to be, after reconstitution, stored or frozen for the next dose. So I think that's a practical point for patients to remember. And we should not mix with any other medication that you are taking. Next slide. It does not interfere. So whatever your chelation and others, that has to continue. It doesn't interfere with anything. NTDT is again a huge proportion of our patients in our country. A study beyond study specifically looked at this cohort, and the results are very encouraging. And we know now that in NTDT, even if we can improve the average hemoglobin by 1 gram per cent, we improve their quality of life significantly. But it is not yet licensed for this indication, and that process is underway, and we will hopefully hear shortly about that. So it does have a role, and we will hear more about licensing in the near future. Next slide. I think I'm just about to finish. What about children? Because I kept repeatedly saying it's for adults. Pharmacokinetic studies are ongoing. The trials for 12 to 18-year-olds are already happening. And once they conclude, then 6 to 12-year also will be evaluated for this drug. But at the moment, less than 18 are not eligible to take this drug. Next slide. So our patients are used to giving Desferal themselves. It is a subcutaneous injections. Can they get it at home? So technically, it is not demanding. But as you can see, because we need to assess response to each dose, it's a new drug even for the doctors. We need to monitor for the side effects. So I would strongly recommend that it is taken under close medical supervision. Next slide. Finally, the cost. The company is not able to disclose a cost to us yet, because it is going to release the drug at the same time in global Southeast Asia. But we know that it will be lower than international prices. It will be marketed under a different name at the same strength. But we have seen, I know this is a difficult molecule, this is not a pill, but imatinib, XJade, many monoclonal antibodies have taught us that we should not really feel disheartened at whatever price it comes at. It is one step forward, and we can only move forward from here. It can only get better. Next slide. So to summarize, we will shortly have a new agent in our armamentarium. Yes, maybe not all our patients will be able to take it straight away, but it will play in the time to come a role in patients with thalassemia. Of that much we are sure. But it is unlikely to replace regular transfusion. There will be people who will respond very well. There will be, not very good responders, but transfusion chelation will still remain the standard of care. But what I hope this drug will do will hopefully usher in an era of novel therapeutic strategies, that there are many other horizons that we are yet to explore, and many other mechanisms. And like this drug, maybe new opportunities will also come. Thank you so much.
Thank you, Dr. Mahajan. You have really nicely and very clearly explained the practical aspects of use of this Luspatercept, and I'm sure you have answered most of the questions which patients and parents must be having in their mind, and we are going to have very few questions in the chat box now. Thank you very much. Now I hand over to Dr. Tulika Seth.
Thank you, everyone. This is indeed a very valuable meeting, and I have the pleasure to introduce Dr. Namita Kumar. As you all know, the patient-directed outcomes and patient voices are very important for us to understand the journey and the needs of patients. And we have an eloquent speaker, Dr. Namita Kumar, who is Head of Communication and Outreach at the Open Platform for Orphan Disease Foundation in Bengaluru. And she is also a patient, and we're very happy to have her here to listen to her. Thank you.
Thank you so much, Dr. Tulika. I'll just share my screen. Okay, so mine is obviously the patient perspective, and I've had the good fortune of taking Luspatercept at a very small dose, and I'll speak about it. So it's my own personal experience, and I was able to get a small dose, 225 mg injections, because at that point I weighed 52 kgs. I got it in June 2019, before PMS took over, when Acceleron and Celgene were still, they were the ones researching the drug, etc. So it was just, I knew somebody and I managed to get it. So my experience so I am basically delta beta thalassemia intermedia. I generally take 1 unit of 300 to 350 ml, 35 to 40 days. But still, I am transfusion dependent and I am on iron chelation. But my initial experience of Luspatercept has been extremely good just with that small dose. So with the 50 mg, I took it just after transfusion, a week after transfusion. And I won't lie, the first week was horrible. I had terrible body pain, like arthralgia, and headache, severe headache, and bone pain, especially hips and the lower back. And it was almost like taking a vaccine, almost like how I took Covishield, the same side effects I experienced for around 5 to 6 days. Literally, I didn't know what to do. I was like, I initially regretted, what is this? But after the 6th day, the pain tapered off. And in the second week, I just noticed a spurt of energy. So my pre-transfusion HB was 9.2. My post-transfusion HB was 10.7, 10.6. So 2 weeks after taking Luspatercept, my HB went to 11. And it stayed that way. So after almost 2 weeks, I had a lot of energy. And I cannot explain, I don't have words to explain the freedom I experienced for almost 2.5 months. For 2.5 months to almost 3 months, I did not take a single transfusion because I had taken 50 mg. And I knew that I had responded very well. I was being monitored. So like my BP every day, I was checking 3 times a day. And since I also don't have a spleen, after around a month, I checked for DVT and the deep vein thrombosis and any events of such sort. So I think I did a Doppler after a month. So constantly monitoring, but it worked very well. I'm fortunate to respond well. And the freedom is like unbelievable. 2.5 months of not taking transfusion, it had a very good impact on my serum ferritin. Yes, I followed it up with Olapis and my usual Desferol, but the ferritin I think everything stabilized. But it was that, unfortunate as it is, I could not, there was no way to access it further. But my initial experience has been just simply great with Luspatercept. I'm very confident that, a lot of us will respond well to this. This is from a patient perspective. Now, I know that doctors have said that so-and-so monitoring has to be done. I think that will be the main thing. So again, I think we are still waiting for it to hit the market. And it's the same story with my friends in Pakistan or Bangladesh. We are waiting for it. And of course, the waiting game is like it's causing a lot of anxiety for most of us, especially the cost factor and affordability. We have from last 2-3 years, we have been debating what's going to happen. And we have been patient organizations, I know, have been advocating. We actually have to see what the company tags it as. And as Dr. Amita Mahajana said, that the cost will definitely be lower than what it is when you compare it to the US or Europe. So it is, since it's an orphan drug approved for use for disease indication, there may be a chance, I don't know, there may be a chance to negotiate with government agencies to include this as a drug for essential distant thalassemia. And it's a big question mark. See, NHM is providing free iron, supposed to provide technically free iron chelation medicines for patients with thalassemia, but it remains to be seen, if they will provide it free of cost for at least some patients. We don't know that. That's another big question that's been coming up in patients' minds. Like, if this drug is indeed going to improve the quality of people's lives, is there a way to advocate for it? And we hope that, all thalassemia patient groups will join, advocate, lobby to provide luspatercept to at least those few patients who can tolerate and respond effectively. And improving health outcomes for a small group of patients will mean they will be better productive citizens who can contribute to the nation. And I think that should be a talking point, at least for a small group, if the NHM or any of the government agencies can sponsor. We don't know. We are yet to see. Once the drug hits the market, that's when we'll be able to understand better how to go about things. So again, I think the doctors have already spoken about the set of risks and side effects. So each of us are though we may have similar genotypes, so phenotypes are definitely, we'll respond differently. I respond but positive, but some may not be able to tolerate the drug, and some may, many of the patients in the US have publicly shared their stories of how luspatercept has worked or not worked for them. So some of us particularly remember Maria's story of severe extramedullary hematopoiesis leading to back pain and other complications. So this may or may not happen with everybody, but I think whichever new drug we are taking, again, our doctors know best. There is a risk versus there is a benefit. So because Maria has openly shared her story that the marrow hyperplasia, whatever she experienced, EMH, led to her bone density becoming. She had a loss of bone density. So I think we need to also check our bone mineral density regularly when we're on the drug. So after the 3 or 4 months, I did check I did my BMD DEXA. There was no change. So I did maintain and monitor some of the parameters. So for me, I don't know, as a patient, the best is the freedom. Best part of luspatercept is freedom, and venipuncture every month or every 15 days. So luspatercept is given in the skin of the upper arm, thigh, or stomach. And so again, the studies indicate 58 out of 153 patients remain transfusion free for 8 weeks. And my own experience was almost 2.5 months, almost 3 months without worry. And in those 3 months, I didn't worry, when is my next transfusion? When am I going to take it? When am I going to plan for it? I really don't have words to tell you the freedom I experienced that short time. Other bonus, so no iron overload. So 3 months, almost 2.5, 3 months of no transfusion, no iron overload. And for me, just the ferritin just came down. Of course, I took usual leptis for 1 month. And I did do the test for all, but at the end of the 3 months without transfusion, ferritin came down to 330 from 1,100. And for me, this was another big bonus. So I think it will, if we get it, some of us, and tolerate it well, monitor all the parameters, it's going to improve our long-term health outcomes. It's a relief from getting the puncture every month or every 15 weeks. And certainly it can reduce the iron chelation dosage, at least for the E-beta and people like me with intermedia. And again, the risk of transfusion hemosiderosis will be very much reduced. And I felt it improved my energy because that level remained for 2.5 months. slowly, yes, it came down after 10.8, 10.7 in the last 2 weeks, but that 11 remained, and I never had this kind of energy before, and definitely I thought my immunity improved greatly. So the biggest freedom I had in that time was to undertake so much more physical activities, which I had never done this before. So I went on 2 major trekking trips and climbed a peak without getting tired. And I can't imagine that today on transfusions. I can't do that at all. That period was like just, I cannot try to, as I said, I don't have words. So I want this kind of freedom for the entire patient community. And I can hope that, we'll unite and fight for a basic health right to get this new therapeutic. And of course, we'll have to come together, set aside our difference, and the economics have to be worked out. And I hope the government agencies will, at some point in time, will be able to advocate, lobby, and let them know that there is a drug which can improve our lives. So I think gene therapy, I believe, at least in India, I don't know, minimum 5 to 8 years, at least we have a hope, which is something new. And of course, it won't replace transfusions, because after that, we will be needing a certain transfusions in that 1 year or something, but whatever, it reduces the transfusion, and we have a hope. So tomorrow is Universal Health Coverage Day, so we have the right to access neotherapeutics, and hopefully we'll work out how we can all access Luspatercept. Thank you.
Thank you so much, Dr. Namita. It was very important for us to understand your patient perspective, and you spoke very eloquently about your experiences with Luspatercept. And I think we all need to heed that call to action and to get to the dream of universal access, especially to this product. Thank you. I hand back to the organizers. Thank you.
Thank you, everyone. And we now move on to the much awaited session, which is the discussion and question and answers. So I request our backend team to now have everybody visible on the screen. And those that are sitting backstage, if you have a question, please, if you just raise your hands, you'll be on the screen, or maybe we can have them on the screen. I think it will probably be better, Darshan, Priyanshi, if we can have everybody on the screen. And yes,
yeah,
the floor is open. There are
Gagan, can I start for Dr. Piga because he has to leave early?
Yes, there are 2 questions in the backstage. I think that's for Dr. Piga. I'll just quickly say them, and then Dr. Mamta, you can take them on, please. One is a question that came from Raju Arora. He's a parent. Is the drug suitable for 21 years old girl whose spleen has been removed long ago? And the second question is, are we doing something about the cost? So now there are no other questions. Over to you all.
Yes, for the age and the spleen removed, the answer is yes. It's true that there is some trend in predicting the result, saying that if the spleen has been removed, a positive response is a bit more likely, but it's just a trend. From the, we say, statistical point of view, there is no difference of spleen out. And for the age is fine. So the answer is yes. And I guess that the second question is not for me.
I think that Dr. Amita or, Amita can take it later. So for Dr. Piga, I had a couple of questions. One is that, have there been any animal studies to really look for teratogenicity related effects?
Yes, obviously there has been. And as the international standard to do this test and to look, and this drug may be teratogenic. Obviously, the doses that have been used in these experiments are by far higher than the equivalent dose we are using with our patient. But in any case, prudently, it's better to know that this drug must not be used at all during pregnancy, obviously. we had a couple of patients that became pregnant during Luspatercept, and nothing happened in the sense that happy end, but this is nothing, it's just an observation. The strong recommendation is not to use. As for most of these type of drugs, is ever the rule.
Yeah, my second question to you was, I heard from another investigator that there are some late responders and that there are reduction in iron overload even in those in whom transfusions were not reduced. So I want your comments.
Yeah, that is true. But again, as I insisted to say, in Luspatercept, in the individual response may be very different. For the iron metabolism and iron overload, I stress more this. That is, it's true that from the statistical point of view, we don't have any significant change in ferritin, liver iron concentration, and where tested the heart iron. But there are interesting trends. So in individual patients, we had very interesting result, similar to the ones described by Namita Kumar. And so I guess that from the scientific point of view, that we will know the story in the next few years. Today, we don't know. So it's better not to expect beautiful result in terms of iron, taking Luspatercept, but to, as for any other aspect, to have a very good baseline evaluation and then to monitor well during the treatment.
Thank you so much. Yeah, any other questions?
I have a question, Dr. Gagan, is it okay?
Yeah, Dr. Sudhir.
Two questions. One is, the therapeutic window, we were trying basically a couple of dose forms, 1 milligram and 1.25 milligram. And if we look at the MDS cohort, they have in fact gone to a higher dose as well. They're up to 1.75. So I wanted to understand the thought process and also, some rationale of why we are not attempting a higher, dose form in thalassemia syndromes. That is one question. The second is, we all know when we report clinical trials and, there are primary objectives, secondary objectives, and we try to, and especially for the regulators, we do try to report our results based on the clinical trial format. But on a clinical practice aspect of it, what proportion of patients who continue to take it for maybe for a year had that actual 33% reduction in the transfer requirement? If we do not, kind of divide it into different weeks, 12 weeks or 12 to 24, because that's how the reports have been generated. But what proportion of patients over a period of time, maybe 1 year, who got it and they were 33% blood requirement reduction? Thank you. So these are two questions I had.
Yes, two very smart questions. For the second, we don't have a clear-cut answer, for the reason that you know better than me, that in transfusion-dependent patient on iron chelation, you have a balance that may go up or down in terms of iron on that, due to that and other factor without any Luspatercept. When you had the Luspatercept, you may have changes, but that are added to the others. So at the moment, not enough patients has been treated in the world to answer very well to your question. That is the point. So my suggestion is not expect greater result, but do baseline very well, and then look at the result of the individual patient. In some patients, you will have very good surprises. As regards the doses, you are right, and I fully agree with you. I'm not so happy with what has been produced by our clinical trials, because to me, for my experience and my opinion, so it's a personal opinion, it's not evidence-based what I'm saying, there is more room for having a good result with some lower doses in individual patients, and there is a room to step up the dose from 1 mg per kg, but not so strongly, going directly to 1.25, but is an opinion. I'm helping my colleagues to verify this opinion, because now we are in the clinical setting in Italy, and that is interesting. You know, what you described is the result of the clinical trial with the rigidity of the clinical trial. But in the clinical setting, if the doctor is expert and prudent, there is room to have some better result, generally speaking, from dosing and changing the dose.
There's another question from one person, that whether it will have any impact on WBC and platelet counts, as he has higher than normal levels. So can he take Luspatercept?
That is another good question, because you know, in splenectomized patient, the platelets level on the average is higher than normal and are active, let's say, platelets. So this per se is predisposing to thrombosis per se. So, but is not a contraindication. So if a patient doesn't have a strong positive history of thrombophilia, we start Luspatercept, obviously with close monitoring, looking at what happened to the platelets, and in the case the platelets are rising up in an important way, we prudently or lower the dose or interrupt the treatment, that is. And for reticulocyte, to a lesser extent, we should have the same type of reasoning. Reticulocyte, that is the new red blood cell. But it's better not to have this reasoning from the patient alone, but from the skilled doctor, possibly discussing with other doctors. So the interaction among us, that is doctors in different hospitals and different countries, that today is so easy, it's very, very important for anything that is new and uncovered by evidence.
Thank you. Shobha ma'am, you have a question.
Dr. Tulika said first ask the question, please. Dr. Tulika said.
Okay, Tulika.
Thank you so much. So my query was that the thrombosis risk appears to be more based on the patient individual themselves. So patients who had thrombosis or have any thrombophilic characteristics are more likely to get thrombosis. So what are the guidelines and how detailed an investigation do we need to do for thrombophilia in a patient before we start?
Good question. My suggestion is to use at first the clinical setting. That is your clinical evaluation of the patient with his history, familiar history. That is often, and in this case too, more important than we say the surrogate markers, because obviously, if possible, it's better to do all the markers that surrogate markers just to check and to balance. But we do not exclude patients only on surrogate markers of thrombophilia, if not a combination of 2-3 different markers where we know that the risk is high.
No, can I ask one question? Just an extension of this, Dr. Piga, that if there is any history of thromboembolic event, would you try this drug?
The answer is in the middle. That is, I go to that event and trying to have an idea and understand if the event is patient-related, and so in this case, I recommend to the patient, no, we do not prescribe Luspatercept for you because it's likely that your risk is high. Or an event is possible fully external, that is some case. So in this case, we say to the patient, we don't know, but it's likely that the event you had is more, let's say, external, is not within you, but is external. So let's prudently try to start luspatercept. So the answer is a bit different in different, but in most of the cases, obviously, it's internal, so we do not recommend.
Thank you. Mrs.
Shobha
Tulip.
ma'am, you want to ask?
Yeah, Dr. Pika, is there any clinical trials going on to test this drug on patients below the age of 18 years?
Yes. The answer is yes. And so even if we are not happy because we insisted to have a full pediatric study since time, but with the prudence of the drug companies, we have now at least one trial running, and we hope to have the result. And I guess that the results in pediatric patients, both in terms of efficacy and in terms of safety, will be something better than what we had today in adult patients.
Yeah,
I'm just
Gagan?
butting in only to say that it's 4:17 by our clock in India, Dr. Piga, and you had to leave 2 minutes back. So I know there is a whole lot of questions sitting in the question answer box, which I'm sure our doctors are going to be able to answer. And whatever they can't answer is something which is directly for you. We will send that to you, and maybe we can get a response for our patients and parents. So I'm going to leave the thank you to Mrs. Tuli, really, because she's been the master force behind this entire thing. But on behalf of the rest of us, I say a big thank you. And Mrs. Tuli, over to you. And then we can continue with the question answers, please.
I will be, of course, coming in the end after Dr. Sunil Bhatt to give my formal vote of thanks. But since Dr. Piga has to leave, so a very special thanks to you, Dr. Piga. I know that you have 2 meetings today, and it was very hard and very difficult to join this meeting. And your presentation has been excellent in a very simple language for patients and parents. And we do hope that this drug comes up soon in our country, and we'll have many more meetings with you later in future to know more about this. Thank you very much for joining us today.
Thank you. Thank you for you. I apologize for this to have to leave, and thank you for your attention and very good luck for the availability of this drug. Thank you very much. Bye-bye. Thanks.
And the webinar continues. Back to Dr. Amita, Dr. Mamta. Dr. Mamta, you've got all the questions in front of you.
Yeah, so we'll go to the next question.
Yes.
Does hemochromatosis hinder the effect of luspatercept on bone marrow? Amita, you could take now the questions.
So, I mean, it has not been really evaluated in detail because, as you can understand, the patient who was selected for the studies were all more or less optimally managed patients. So, and it was a prerequisite that they have a normal liver function. So, no patients with very severe hemochromatosis have actually been tried. So, we don't know that. And I think that was something that will come from the real world data. I tried to ask the company because we do have a system of phase 4 studies that after the marketing, where the drug is already in the market, if they have some information on this, but there isn't a formal phase 4 study ongoing. So this is something that we will have to find for ourselves because a number of our patients may be in that category.
Thank you.
Can I ask, Dr. Mamta, can I ask one?
Yes,
yeah, carry on, please.
I think Sunil's network is a problem.
Yeah.
You can ask Dr. Khanna.
I can no, yeah. I'm taking from the chat box only. There are some questions comparing this drug with the thalidomide. Yeah. They say that it's a cheaper drug and it has been tried in children and it works similar to this drug. Why? And both the drugs can have potentially serious side effects. Why try this new drug when we already have thalidomide? Dr. Amita, please.
Sir, no, it's exactly for that reason that a multi-centric study on thalidomide is ongoing. I mean, Dr. Mamta is a part of, her center is a part of that. We are participating. because the ground realities in India do demand that, and we maintained it for a long time, that anecdotally there were wonderful responses attributed to thalidomide. Unfortunately, it was never evaluated in a formal, the way it should have been. And belatedly, we are trying to do that attempt and answer this, because this multicentric study that is ongoing is, to my mind, the largest prospective study in the real world, where we are trying to do it as honestly as possible, and we will know that answers. But yes, I guess there will be room for thalidomide, there will be room for Reblozyl, because there is no magic bullet for, so it will be different strategies that will work for different patients. And hopefully we will find a way, even in thalassemia, to personalize medicine based on responses, patient choices, and patient disease profile or biology of the disease in that patient. So it is one more addition, but we are evaluating thalidomide, and hopefully we'll be able to share at least to a certain extent that answer.
From
So in
your
fact-
experience, Dr. Amita, do you think thalidomide might come? So far,
So
whatever the preliminary reports that you have gone through.
Sir, again, we are identifying, excellent responders, just like Reblozyl almost. And our own reservations about thalidomide have been about the toxicity profile.
Yeah.
So again, the study that is doing is trying to monitor very actively the side effects and also the efficacy. But yes, we are seeing unique patients that are really their transfusion interval has gone down. But I think it will have its own place. Whether this study will be the final answer, I don't know. But at least it will answer some questions and then give us some way forward as to, should we be not recommending it at all? Should we be recommending it to select patients? And is there any way that we can predict responsiveness? The best thing would have been if Reblozyl studies could have identified who is likely to respond, and that is not there. So I think if somebody wanted to try, they are committed to taking 5 doses at least to know whether they will respond. And in my mind, at least patients who have severe alloimmunization, patients who are having anaphylactoid reactions to transfusions, the government may consider, like emcizumab is licensed for select patients with inhibitors. Maybe the government may consider, despite its cost, certain select patients for a trial of Reblozyl.
Yeah,
so if I may
we
add,
can't
Dr.
ignore this
Khanna.
4% risk of thromboembolic events. We can't ignore them.
So if I may add up about thalidomide, first
Yes,
of all,
madam.
we are doing a trial in all about 12 years and not in pediatric patients as yet. There is no study which has given us a proper dose in pediatric age group. We are still doing dose finding in older age group, after which we might try in pediatric age group. Second part is about thalidomide. It has wonderful results in some patients, as Amita has mentioned, and not so good in some patients. And there have been some side effects which we need to make a note of and see how to address them, though we have not had any serious adverse events or mortality so far, touch wood. So that is a good part of thalidomide. The cost is, of course, so much lower that it will be a very, very good drug to use for thalassemia if it works well. But as of now, we should not be, allowing people to use it randomly, which has happened in the past. And that is the reason we decided to come together as multicentric trial so that we showcase scientifically what should be done with thalidomide, what should not be done. And that, I think, will be unraveled once this trial is over.
Thank you, madam. Mrs. Tully wanted to say something.
It's for the, of course, the Indian experts now. We have come to know, we have been informed by some parents that this medicine, Reblozyl, Luspatercept, is available in Indian market, and it has been labeled as rupees 13,000 per injection. So I don't know what is, from where they are getting it, or is it something. I want something to come out. I'm a non-medical person. Some suggestion from your side, some advice that not to buy this drug at this moment because it is not available. So this is very important, question that I wanted to raise here, and I brought it to the notice of BMS as well.
And the drug is not currently available.
Yeah.
We can import that drug as we do imported drugs, but that is even more expensive because we pay an import duty. But what you are describing in that way, I don't think anybody should purchase, because it is very unlikely that that is the product that we are
authentic drug.
Yeah.
Sunil has something to say.
No, I just wanted to comment on the same thing. I think Dr. Mahajan is already answered, and it can be imported through the patient assistance program, which is there is some provision of import, duty exemptions for some of these drugs, so that can be done. But there is no shortcut, and you're right. There are some ads which are floating around in different websites, which shows cost as low as 5,000 to 7,000 as well. But I think it's all fake, so I think we should alert everyone to not use them. Thank you.
Dr. Mamta, would you just quickly like to see the questions?
Numbers
are growing.
Yeah, so there are some which are about when will the Luspatercept come in India, which we have already spoken about. How is it different from thalidomide? We have just discussed. It is different because thalidomide obviously acts differently, and it is a cheaper drug, oral drugs. There are many differences. Then there is a question about severe bone pains amongst patients in US, Europe. I think Amita, could you take this? Have you seen any such side effects? I don't know.
So that is the commonest side effect, and at least maybe up to 20 to 30% will feel something, but it is usually self-limiting. And after 5 to 7, that is what is in the literature, that has 5 to 7 days, they have been able to stop. I mean, we know from Kelfer that about 20%, 30%, and a significant proportion need to even discontinue. So most patients with Reblozyl have not required discontinuation of the drug. With mild normal analgesia, they've been able to manage. Of course, an occasional patient may have very disabling arthralgias, and that's because of the mechanism of action is through the it was designed as a drug for the bone density. So that is a significant problem, but we don't have any experience in our patients, so we will have to wait and see.
Yeah. There is a comment by someone from
experience on the bone pain. Maybe if she's still there, she can comment on that. Dr. Namita.
Namita, in fact, she said that for 6 days she has very bad pains.
Yeah, 6 to 7 days. I mean, it was terrible. It was just like Covishield or vaccine, if I can draw a comparison. But I had a lot of headache. Bone pain, as I said, hips, lower back. But after the 6th day, it came down drastically. By the 7th or 8th day, it was gone.
And but did it repeat when you took the next injection?
I never got a chance, ma'am, to take them. I just got 2 vials of 25 mg, 50 mg. And by then, I think BMS took over Acceleron and Celgene. So I never got a chance.
Okay. No, this is also important to know whether it will recur every time an injection will be taken.
Yes, yes. We can't afford 1 week of pain.
Of tolerance, actually. When you continue it, there is some reports of tolerance. So the bone pains and the other side effects do reasonably come down.
Okay. So there's some comment by one, I think a professional from Greece, Athens, who has said that they have used Luspatercept in 18 patients, 15 were splenectomized. All of them had an increase in the interval between transfusions. And despite extending the interval, their hemoglobin levels remained stable, amount of supplied blood reduced. Significant role was played by stable amount of blood. And also she has said that there were no deviations and we could determine whether or not the medication was effective. Several patients had comorbidities that did not influence the response to Luspatercept negatively. In a patient with a history of thrombosis who was receiving anticoagulants, she has, I think, not finished the statement beyond that. But I think what she's trying to say is that they have had very good results and outcomes with Luspatercept in their 18 patients.
The NTDT data is actually very encouraging.
Yeah.
And in fact, in the Beyond study, there wasn't a single episode of thrombotic event, even though that was the, NTDT are expected to have higher thrombotic event. Surprisingly, that hasn't happened. And 77% had, what they qualified as response was a minimum elevation of 1 gram. And 83% of them remained transfusion independent during the course of the study.
That's true. That's true.
Dr. Mamta, maybe what we can do is the rest of the set of questions, since our time is almost up and we still want to hear Dr. Bhatt. So we'll actually put them together and share them with, all of you, and you can give us the answers which can be sent to the respective.
Great.
And
I think so.
Yeah, let's hand it over to Dr. Bhatt and then of course, Mrs. Tully.
Yeah,
So over to you, Dr. Bhatt. And
so good afternoon, everyone. I don't think there is anything for me to add. But I got a couple of messages that all the conversations are happening in English. So if I'm permitted, I can probably take in one language, and that can be Hindi, probably, which can be understood by the most. So that probably is the only thing I think can be added upon what has been said.
Please.
Sorry, ma'am.
Yes, please go ahead.
Yeah, my Hindi is not great when I speak in public, but I'll try my best. Okay, I've noted down some of these things which was already discussed. So सब लोगों को पहले तो नमस्कार. मेरे को पता है कि ज्यादातर थैलेसेमिक्स और उनके केयरटेकर्स ने ज्वाइन किया आज की मीटिंग को. काफी एंथुजियाज्म है इसको लेके, क्योंकि आपके जो क्वेश्चंस हम देख रहे हैं चैट बॉक्स में, काफी सारे क्वेश्चंस आपको इस सब्जेक्ट पे हैं, और हम कोशिश करेंगे सब क्वेश्चंस को आपको डायरेक्टली आंसर करने के लिए. लेकिन जो हमने अभी तक बात करी है उसको समराइज करने के लिए मैं 5 मिनट लूंगा. पहले तो डॉक्टर एंटोनियो पीगा जो अभी नहीं है हमारे साथ, वो मीटिंग लीव किए हैं, उन्होंने एक अच्छे से समराइज किया कि जो लुस्पाटरसेप्ट का डेवलपमेंट कैसे हुआ और उसका अभी जो स्टेटस क्या है. डॉक्टर महाजन ने काफी प्रैक्टिकल एस्पेक्ट्स डिस्कस किए, और स्पेशल प्रैक्टिकल एस्पेक्ट्स में हमारी कंट्री में क्या इम्पैक्ट होगा जब ये दवाई अवेलेबल होगी. समराइज करने के लिए, थैलेसीमिया जो प्रॉब्लम है, इसमें हम तीन वर्टिकल्स या 3 किस्म की ट्रीटमेंट्स के बारे में डिस्कस करते हैं. एक तो कि उनका जो बेस्ट केयर, सपोर्टिव केयर कैसे कर सकते हैं. ब्लड ट्रांसफ्यूजन और किलेशन जो है वो अभी भी थैलेसीमिया बच्चों के लिए जिनको ब्लड ट्रांसफ्यूजन लगता है वो बेस्ट सपोर्टिव केयर है, मतलब वो पूरा पिलर है ट्रीटमेंट का. दूसरा जो एस्पेक्ट है कि इसको परमानेंटली क्योर कैसे कर सकते हैं, और क्योर के लिए डॉक्टर पीगा ने जैसे हमको चार्ट दिखाया था, ट्रांसप्लांट या जीन थेरेपी क्योर करने का एक ऑप्शन है. वो तो तीसरा एस्पेक्ट है जिसके लिए हम आज पूरा डिस्कशन चल रहा है, वो कि क्या कोई और चीजें हैं जिससे हम इन बच्चों का ब्लड रिक्वायरमेंट या इन बच्चों का जो क्वालिटी ऑफ लाइफ है, इन बच्चों का कोई सपोर्ट सिस्टम हो सकता है जिससे कि हम इनमें जो है ब्लड रिक्वायरमेंट की कमी हो, जिसको हम कॉम्प्लीमेंट्री या सप्लीमेंट्री ट्रीटमेंट बोलते हैं. तो उसमें जो आज हमने जो दवाई डिस्कस करी जो है लुस्पाटरसेप्ट, ये दवाई हमको पता है, हम काफी सालों से डिस्कस कर रहे हैं, और काफी सालों का जो रिसर्च है उसमें अब उसका जो कंक्लूजन ये था कि ये जो दवाई है अब एडल्ट्स का मतलब है जो 18 साल से ऊपर के लोग हैं, उनके लिए ये अब दवाई अप्रूव्ड है. किन के लिए अप्रूव्ड है? जो थैलेसीमिया ब्लड ट्रांसफ्यूजन लेते हैं, जो थैलेसीमिया ब्लड ट्रांसफ्यूजन लेते हैं उनके लिए अप्रूव्ड है. हमने ये भी डिस्कस किया कि जो ब्लड ट्रांसफ्यूजन नहीं लेते हैं, जिसको हम नॉन ट्रांसफ्यूजन डिपेंडेंट थैलेसीमिया कहते हैं या थैलेसीमिया इंटरमीडिएट कहते हैं, उसके जो इनिशियल रिजल्ट्स हैं वो काफी एनकरेजिंग है. उनमें भी लुस्पाटरसेप्ट से फायदा होगा. ब्लड ट्रांसफ्यूजन रिक्वायरमेंट जो है कम, अनफॉर्चुनेटली उनको ब्लड ट्रांसफ्यूजन तो नहीं मिलता है, लेकिन उनका जो रिक्वायरमेंट है, हीमोग्लोबिन का जो इंप्रूवमेंट है वो बेशक होगा. लेकिन अभी थैलेसीमिया जो नॉन ट्रांसफ्यूजन डिपेंडेंट है, इंटरमीडिएट है, उसका जो आगे की स्टडीज चल रही है, तो अभी अप्रूवल जिसको हम बोलते हैं रजिस्टर्ड अप्रूवल अभी उनको नहीं मिला है, लेकिन उनका भी इंप्रूवमेंट जो है इनिशियल स्टडीज में देखा गया है. तो अब हम वापस आते हैं ट्रांसफ्यूजन डिपेंडेंट थैलेसेमिक्स में, जिनको ब्लड ट्रांसफ्यूजन की जरूरत पड़ती है. तो उसमें जो लुस्पाटरसेप्ट का क्या रोल है और कैसे दे सकते हैं, उसके क्या हमको प्रिकॉशंस लेनी पड़ेंगी. पहले तो ये कि ये जो दवाई है ये इंजेक्शन के द्वारा दिया जाता है, और 3 हफ्ते में एक बार इंजेक्शन दिया जाता है. पहले एक छोटा डोज दिया जाएगा 1 मिलीग्राम पर केजी के हिसाब से. अगर उसमें कोई इंप्रूवमेंट नहीं आती है तो ये डोज हम बढ़ा सकते हैं 1.25 मिलीग्राम पर केजी तक भी जा सकते हैं। लेकिन अगर किसी का 5 डोज तो कोई इंप्रूवमेंट नहीं आता है, तो ऐसा एक्सपेक्टेड है कि इसको, ये जो थैलेसीमिक जो पेशेंट है, इसमें एक्सपेक्टेशन नहीं है कि इंप्रूवमेंट होगा, तो इसलिए हम इसको उसके बाद और कंटिन्यू करने की कोई जरूरत नहीं है। दूसरा जो है, जिन लोगों में इससे इंप्रूवमेंट आएगी लुस्पाटरसेप्ट से, ये देखा गया है कि उनका जब हम कंटिन्यू करते हैं इंजेक्शंस, उनका जो रिस्पांस है वो कंटिन्यू करता है। ऐसा नहीं है कि उनका 2 महीना 3 महीना रिस्पांस आया उसके बाद वो रिस्पांस आना बंद हो जाता है। मोस्ट ऑफ द जो पेशेंट्स है उनका रिस्पांस जो है वो कंटिन्यू करता है जब तक उनको लुस्पाटरसेप्ट इंजेक्शन दिया जाता है। लेकिन यहाँ पे एक सबसे इंपॉर्टेंट बात जो हम कहना चाहते हैं आपसे, कि ये थैलेसीमिया का क्योर नहीं है। जब आप लुस्पाटरसेप्ट लेते हैं, ब्लड ट्रांसफ्यूजन्स और किलेशन को कंटिन्यू करना पड़ेगा। सिर्फ जो एक एडवांटेज ये है कि ब्लड की जो रिक्वायरमेंट है वो कम होगी। अब वो कितनी कम होगी, ये हर पेशेंट का अलग अलग रिस्पॉन्स हो सकता है। कुछ पेशेंट्स का जो रिस्पॉन्स है, ऐसा हो सकता है कि उनका रिक्वायरमेंट 50%, 60%, 70% तक भी कम हो जाए। और जो स्टडी इन्होंने की थी उसमें 10% लोगों का जो रिस्पॉन्स है, 50% के आसपास उनका ब्लड का रिक्वायरमेंट कम हो गया। उसका मतलब ये है कि अगर किसी को 1 महीने में ब्लड मिल रहा था, उसका जो रिक्वायरमेंट है वो 1.5 महीने का है। मतलब उसका जो 50% के आसपास में इंप्रूवमेंट आया। 20 से 25% लोगों का जो रिक्वायरमेंट है ब्लड का, वो 33% तक कम हुआ। उसका मतलब है अगर कोई किसी को 30 डेज में ब्लड मिल रहा है, तो अब उसको ब्लड जो है 40 डेज में देना पड़ रहा है। तो एक मैसेज ये है कि रेस्पॉन्स सभी में इक्वल नहीं होगा। जिनमें रेस्पॉन्स होगा उनमें भी एक्सपेक्टेड है कि ब्लड की रिक्वायरमेंट कम होगी, ना कि ब्लड का ट्रांसफ्यूजन उनको बंद होगा। तो ये एक सबसे बड़ा मैसेज ये है। दूसरा ये कि हर चीज में, हर दवाई में अपने अपने साइड इफेक्ट्स हैं, और इस दवाई के भी अपने साइड इफेक्ट हैं। जो 4 या 5 साइड इफेक्ट आज डिस्कस किए गए थे, उनमें सबसे इंपॉर्टेंट पहला साइड इफेक्ट था थ्रोम्बोएम्बोलिज्म या थ्रोम्बोसिस, जिसको हम लेमन लैंग्वेज में क्लॉटिंग बोलते हैं। तो हमारा वेनस सिस्टम में क्लॉटिंग हो सकती है, जो कि लंग्स में या ब्रेन में हो सकती है, जो हमने कुछ एपिसोड्स थैलेडोमाइड से भी देखे हैं। तो सिमिलर जो है थ्रोम्बोटिक इवेंट्स हो सकते हैं। और ये थ्रोम्बोसिस, ये क्लॉटिंग जो है, ये कुछ लोगों का रिस्क उनमें ज्यादा होता है, जैसे जिनका स्प्लेनेक्टमी हुआ है, या जिनका प्लेटलेट काउंट ब्लड में ज्यादा है, या जिनका ऑरल कॉन्ट्रासेप्टिव चल रहा है, या उनको पहले किसी को थ्रोम्बोसिस का ऐसा कुछ इवेंट हुआ है। तो इनमें हमको केयरफुली डॉक्टर्स का डिस्कस करके ये दवाई हम दे सकते हैं, लेकिन इस एक इम्पॉर्टेंट कॉम्प्लिकेशन को हमको देखना पड़ेगा। दूसरा जो है ब्लड प्रेशर बढ़ना। ब्लड प्रेशर बढ़ सकता है काफी। जो ये स्टडीज की गई थी, तो उसमें 20-25% लोगों का जो थैलेडोमा ये चल रहा था, उनमें ब्लड प्रेशर की जो इंक्रीज हुई थी। तो इसलिए ब्लड प्रेशर को मॉनिटर करना भी बहुत जरूरी है। तीसरा जो है, क्योंकि इसमें ब्लड रिक्वायरमेंट कम हो रही है, किसी कारण से कुछ लोगों में ब्लड का जो मैन्युफैक्चरिंग है, जिसको हम बोलते हैं एक्स्ट्रामेडुलरी हेमाटोपोइसिस, जिसमें लिवर स्प्लीन का साइज बढ़ना या बोन्स में मैन्युफैक्चरिंग बढ़ना ब्लड का, उससे उनमें कुछ प्रॉब्लम्स आ सकती हैं। और सबसे डेंजरस जिसको हम मानते हैं पैरालिसिस जैसा हो सकता है। बहुत रेयर है, लेकिन वो भी एक कॉम्प्लिकेशन हो सकती है। इसलिए उसकी जानकारी भी होनी चाहिए शुरू करने से पहले। प्रेगनेंसी और ब्रेस्ट फीडिंग में ये दवाई नहीं यूज कर सकते, क्योंकि इसका जो साइड इफेक्ट प्रोफाइल है, अभी प्रेगनेंसी और लैक्टेशन या जिसको ब्रेस्ट फीडिंग बोलते हैं, इसमें अभी स्टडी नहीं किया गया है। और जो एनिमल एक्सपेरिमेंट से देखा गया कि शायद फीटस पे या शायद बेबी पे, गर्भवती महिला पे उसका इफेक्ट हो सकता है। तो वो एक इम्पॉर्टेंट मैसेज है एडल्ट्स के लिए जो अपना प्रेगनेंसी प्लान करना चाहते हैं या ऑलरेडी प्रेग्नेंट है, तो ये दवाई शुरू ना करें। कुछ और साइड इफेक्ट्स हैं जो इतने सीरियस नहीं है, जैसे हेडेक, बोन पेन्स, जॉइंट पेन्स या नौशिया का फीलिंग होना। ये साइड इफेक्ट्स देखे गए स्टडीज में, लेकिन ये साइड इफेक्ट्स इतने सीरियस नहीं, और ये देखा गया कि जब हम दवाई कंटिन्यू करते हैं तो साइड इफेक्ट्स का जो प्रेवलेंस कम होता है। तो इन समरी, क्योंकि साइड इफेक्ट प्रोफाइल भी है और पेशेंट टू पेशेंट वेरिएबिलिटी है, तो ये दवाई हमेशा आपके हेमाटोलॉजिस्ट या आपके जो थैलेसीमिया के जो स्पेशलिस्ट है, जो आपका ट्रीटमेंट करते हैं, उनके बिल्कुल क्लोज ऑब्जर्वेशन में लेना चाहिए। और बहुत ही केयरफुली इन सब चीजों को हमको फॉलो करना चाहिए। ये भी हमने डिस्कस किया कि क्या हमको दवाई शुरू करने से पहले ये पता चलेगा कि किसकी रिस्पांस हो सकती है, किसका रिस्पांस नहीं हो सकता। अभी तक कोई ऐसा मैकेनिज्म नहीं है देखने के लिए कि कौन से पेशेंट्स में रिस्पॉन्ड होगा, कौन से में नहीं होगा। तो इसलिए ये जब शुरू करेंगे उन पेशेंट्स को 4-5 डोजेस के बाद ही हम ये डिक्लेयर कर सकते हैं कि क्या किसी एक पर्टिकुलर पेशेंट में कंटिन्यू करने की इसकी जरूरत है या नहीं है। लास्ट जो क्वेश्चन था वो सबका आपके काफी आपने चैट बॉक्स में भी डाले हैं, वो है कॉस्ट को लेके और अवेलेबिलिटी को लेके। अभी ये जो इंजेक्शन है अवेलेबल वेस्ट में अवेलेबल है, यूरोप में अप्रूव्ड है, यूएस में अप्रूव्ड है, तो हम इसको बाहर से अभी इंपोर्ट कर सकते हैं। अभी ये इंडिया में फ्रीली अवेलेबल नहीं है। इंडिया में रजिस्टर हो चुका है, इस साल 2022 में रजिस्टर हो चुका है, लेकिन अभी मार्केट नहीं हुआ। मार्केट का मतलब अभी अवेलेबल फ्रीली नहीं है। हम होप करते हैं कि जनवरी या फरवरी में जो कंपनी इसको मार्केट कर रही है हो सकता है इंडिया में इसको अवेलेबल करे। हमारा ये भी होप है कि ये दवाई जब इंडिया में मार्केट होगी इसका कॉस्ट इंटरनेशनल मार्केट से कम होगा, क्योंकि कॉस्ट जो है बहुत ही प्रोहिबिटिव है। हम डॉक्टर पीगा ने हमको एक स्लाइड दिखाई थी जहां पे उन्होंने दिखाया था कि जो यूएस में कॉस्ट है 1 साल की ट्रीटमेंट 50 किलो के पेशेंट के लिए वो $124,000 $124,000 विच इज वेरी एक्सपेंसिव। और उन्होंने ये भी दिखाया था कि यूरोप में उसकी जो कॉस्ट है ऑलमोस्ट 50,000 यूरो पर ईयर की कॉस्ट है। तो वो हमारे कंट्री के लिए, हमारे पेशेंट्स के लिए बिल्कुल अनअप्रोचेबल है। लेकिन हम लोग सब, आई थिंक डॉक्टर नमिता ने एक अच्छा सा एक स्लाइड शो किया था कि क्या आप लोग उसके लिए कुछ कर रहे हैं। हम लोग सब काफी इनडायरेक्ट डायरेक्ट प्रेशर्स डाल रहे हैं जिससे कि हमारे पेशेंट्स को, जैसे नोवार्टिस ने एक्सजेट कॉस्टुंडा में लॉन्च किया था, वैसे ही कुछ अरेंजमेंट अगर वो करके इसका कॉस्ट काफी रिजनेबल लाएं तो उसका, बट अभी कहना मुश्किल है कि क्या कॉस्ट होगा, क्योंकि कंपनी ने भी डिक्लेयर नहीं किया है कि कॉस्ट इंडिया में क्या होगी, और जब लॉन्च होगा तो तब we will have to see. So I think ये समरी था पूरा जो हमने आज डिस्कस किया, और thank you very much Thalassemia India first of all to have a session like this. I think it was a very well conceived and well required session, because I think there has been a lot of buzz in the patients and the families about the excitement of the new drug, and rightly so. And it's very good to prepare ourselves, both the doctors, the patients, and the caretakers, and you know, when it's available, so that we are ready to launch, and we are also ready to you know, extend this help to as many patients as possible. So thank you for having me. Thank you.
Thank you, Sunil. Wonderfully concluded with all the points covered very nicely, and Hindi में बोलने के लिए शुक्रिया, क्योंकि patients समझ पा रहे हैं अभी. Thank you. Back to Gagan. Thank you very much.
So I now request Mrs. Tuli to now come in, give the formal vote of thanks for today.
So before I give formal vote of thanks, मैं 3 चीजें कहना चाहूंगी. एक तो ये पहली ड्रग है जिसके बारे में अभी ड्रग आई नहीं है, इंडिया के अंदर अवेलेबल नहीं है, कॉस्ट का पता नहीं है, और उसके ऊपर इतनी चर्चाएं हुई हैं. किसी भी कॉन्फ्रेंस देख लो, चाहे फिजिकल मीटिंग हो चाहे वर्चुअल मीटिंग हो, तो हमारा डायरेक्ट मैसेज जो है बीएमएस के लिए है कि आपको एशियन कंट्रीज के लिए, मैं इंडिया नहीं कह रही, you have to keep a special price for the thalassemics, whether it is major or intermediate later on, you know, so that most of our patients can make use of that. And then another thing for my patients and the families is, मैंने बहुत सी इसके ऊपर international meetings attend की हैं, और उसमें से जो मुझे ज्ञान और knowledge मिली है, तो मैं उसमें सबसे ये सुनती हूँ डॉक्टर से कि अब ये टाइम आ गया है कि हमें सबसे पहले तो अपने आप को गुड हेल्थ में रखना है. कोई भी नई ड्रग आएगी या कोई भी नई, अगर आप जीन थेरेपी की भी बात करते हो, जीन एडिटिंग की बात करते हो, या किसी को इवन बोन मैरो के लिए भी, हमको सबसे पहले अपने आप को बेस्ट ऑफ द हेल्थ में रखना है. उसके ऊपर आपका फोकस बिल्कुल नहीं हटना चाहिए. फोकस वहीं पे होना चाहिए. जैसे जैसे टाइम बदलेंगे, जैसे कोई नई चीजें आएंगी, हम कभी 1970s में सोच सकते थे कि हम यहाँ पे 2022 में बैठ के एक ऐसे ड्रग के बारे में बात करेंगे जिससे कि हमारा ट्रांसफ्यूजन का गैप हो सकेगा? मैं तो बिल्कुल ड्रीम भी नहीं कर सकती थी. सो माय मैसेज टू ऑल माय थैलेसेमिक्स एंड ऑल द थैलेसीमिया फैमिली इज, आवर फोकस हैज टू बी ऑन आवर चाइल्ड्स हेल्थ. उसका ट्रांसफ्यूजन किस टाइम पे कराना है, मीन ट्रांसफ्यूजन, उसका हीमोग्लोबिन कितना होना चाहिए, उसका किलेशन सीरम फेरेटिन कितना होना चाहिए, हेपेटाइटिस के बारे में उसको सेफ ब्लड देना चाहिए एंड ऑल दैट. फिर जैसे जैसे चीजें आएंगी तो उसके हिसाब से हम आगे चलेंगे. So now it's time, we have come to the close of the today's webinar on Luspatercept, And I have been given this role to extend my formal vote of thanks. So on behalf of Thalassemics India and Thalassemia Patients Advocacy Group, of which Namita is already here as a speaker, So I formally like to extend my heartfelt gratitude. That's the word I always use, because it's coming from here, to all my chairpersons and the speakers, Dr. Antonio Piga, Dr. Mamta Manglani, Dr. V.K. Khanna, Dr. Tulika Seth, Dr. Sunil Bhatt, Dr. Amita Mahajan, and to our very special patient speaker, Dr. Namita A. Kumar. We are so grateful to each one of you for sparing your valuable time on a chutti day like Sunday. And in future, I will keep it in mind not to trouble you and keep it on a holiday, and try to keep it on other day, not to disturb you. And our special thanks to our supporting friends as always, Narayana Health and Cipla Company. And thanks Showcase Events, Gagan, my colleague, and Manage Health Foundation for organizing this event in a very professional and beautiful manner. So she takes away a lot of my, worries and all that by arranging everything at the last minute. So lastly, I thank all the participants who have joined us. And I asked Gagan just a few minutes back that how many of them are here. 310 had registered, but we have two platforms. And the total people who are here who are attending and listening to this talk on the webinar is 226, which is a very good number. And I hope that you will you have taken and you have learned more about this drug. As I said, this is a drug. जब मेरे से पीछे मैं पिछले हफ्ते किसी के साथ बैठी तो उन्होंने मुझे कहा एक वर्ड में बताओ इस ड्रग के बारे में, मुझे कुछ पता नहीं है. मैंने बोला एज ए पेरेंट अगर मुझसे पूछोगे तो एक अद्भुत ड्रग है ये मेरे लिए, एज ए कि मेरे बच्चे के लिए अगर मैं अफोर्ड कर सकती हूँ और अगर उसको सूट की तो उसका ट्रांसफ्यूजन गैप पड़ जाएगा. लाइक नमिता सेड, फ्रीडम, that's the word, that's the catch of the day. We'll have freedom from the daily breaks or the monthly visits to the hospitals and all that. Hamara iron overload kam ho jayega. And we all hope that we will meet again and discuss about this as this drug is available. We'll have new challenges, as Dr. Amita has said. और मैं वो कमेंट उस पर नहीं करना चाहती हूँ, पर मुझे मालूम है कि किस तरह से सिलेक्टेड पेशेंट्स के ऊपर वो स्टडी की गई है. So we have to take everything in the positive manner. From today onwards, while thanking each one of you once again with my folded hands on behalf of Thalassemics India and TPAG, and I thank each one of you because you're always there with us. You are the ones, when I look at the adult patients, I always first remember you people, and then, thanking you, and then look at the adult patients because they are the ones from whom you have taken care of them. And that is why it's because of all of you that they have been able to grow up and, doing very well in there. Of course, it's a challenge because इतने हमारी country में patients हैं कि हम चाहते हैं कि हम सब तक पहुंच पाएं और वो भी उसी तरह तरक्की करें जैसे कि और कर रहे हैं. But that's not possible. That's something else. We will discuss it on some other platform, So thank you very much once again for your time. Thank you, each one of you.
Thank you, ma'am. Thank you for a wonderful webinar. Though I was in another webinar till 2 o'clock, but I thought this was really worth it. I'm happy I was associated with it.
Thank you, madam, for joining.
Thank you.
Thank you.
Thank you.
There are many.
Thank you, everyone, for joining.
There are many people who are asking us that how can they see the recording of this webinar, and if there's anything they can ask us. Yes, very soon we will be putting up this entire recording on Thalassemics India YouTube. So if you follow us on our socials, or Thalassemics India social handles, you will get totally updated on when it's going out on YouTube and what is the link, because we will not be sending out the links individually to anyone. So thank you, everyone.
Thank you.
Thank you.